Hello, everyone, and welcome to today's webinar. It's being recorded, and the recording slides and resources will be made available via email shortly. Please use the chat box to share your questions, and we will answer them towards the end of the program. Please also identify yourself when you ask your question. Good morning, and welcome to the primary care and oral health community and also members of the news media. We are pleased to welcome you to today's event. My name is Ann Greiner. I'm President and CEO of the Primary Care Collaborative. And today we're going to be releasing a report on oral health and primary care integration. Let me begin by reflecting a bit on why this is so important. We have a model of primary care that is, we have a vision of primary care shared in the shared principles of a comprehensive primary care that is integrated and coordinated. Sadly, our system really does not reflect that. Most patients do not truly get comprehensive care, and that is why we are here to demonstrate that this kind of care is happening around the country, and our report exemplary practice. What we need to do is shape policies so that these practices can spread. And I'm going to tell you that I'm having a little bit of technical difficulty, so just give me a moment while I get my run of show here. So sorry about that. As you know, here in this space, we often can have these kinds of difficulties, and hold on. And I appreciate your patience. Okay. The PCC, for those of you who may not know our organization, we are a nonprofit, and we unify and engage diverse stakeholders, promote policies, and share best practices to lift up high-performing primary care. We have 60 organizations that are a part of our membership and thousands of supporters, and we're dedicated to advancing an effective and efficient health system built on a strong foundation of primary care, including the patient-centered medical home. For those of you who are acquainted with the patient-centered medical home, you know that it features many of the things that we're trying to achieve in our health system: more comprehensive, coordinated, and integrated care. This report that we're releasing today is really part of a movement to move towards more integrated primary care. And in fact, immediately following this presentation, the Bipartisan Policy Committee is also going to be releasing a report on integrated primary care in the behavioral health space. And we've learned a lot from integration of behavioral health into primary care and are really leveraging those lessons in the oral health space. Now let me introduce Darylyn Moyer, who's President and CEO of or Executive Vice President and CEO of the American College of Physicians and Chair of the PCC Board. Darylyn, over to you.
Good morning, and thank you, Anne, and hello, everyone. I'm also a practicing internal medicine physician in a primary care practice on the front lines of care in an underserved area in Philadelphia. On behalf of the Primary Care Collaborative, its board of directors, which I chair, and its 60+ members, one of which I lead, I'm pleased that you've joined us this morning for the unveiling of this significant report. I want to first acknowledge and thank the advisory group that guided the overall project and contributed to the final report we will learn about today. The group representing patients, oral health clinicians, primary care clinicians, health plans, and purchasers had many meetings over Zoom during the past year to inform PCC's work and provided thought leadership on the future of oral health and primary care integration. We thank them for their time and their contributions. Second, today marks the culmination of a project made possible by the Carequest Institute for Oral Health. Until very recently, you probably knew this organization as the DentaQuest Partnership, for oral health advancement. After a name change and rebranding, it is now known as the Carequest Institute. We're pleased to have with us at this event the CEO of the Carequest Institute, Dr. Maisha Minter-Jordan, and some of her staff. You'll hear from Dr. Minter-Jordan in a few minutes during the panel discussion. Again, we thank the Carequest Institute for their funding and support of this report and work that it took to produce it. And, you know, I could have told you so many stories today. I always think it's important when we have presentations to anchor it to a person. So many patients that have come across my path in my 35 plus years of being a practicing physician, including a patient that I saw who was in her early 50s. She was a diabetic patient who was on insulin. She had high blood pressure, heart disease. She was on a blood thinner. She had depression. And she was referred to see us urgently. Frequently, primary care practices have those urgent care slots. And the emergency room that we were connected with had her seen urgently by us after they saw her quickly. Turns out that she had been seen in local emergency rooms over 12 times in the preceding year, always with blood sugars over 400, blood pressure that wasn't well controlled, depression that wasn't well controlled. And as it turned out, it was all about her teeth. What had happened was she had had poor dentition. She didn't have good dental care growing up and had multiple broken teeth in her mouth. And every time one of the worst teeth would act up, she would go to the emergency room. They would give her a short course of antibiotics, some medications to help abate the pain, but she couldn't afford everything. So in order to pay for the antibiotics and the other meds that she received in these ED visits, she would short herself on her insulin and hence developed a vicious cycle of the tooth pain getting worse, her going to the ED, not really telling them that much about her dental history, and nor about the fact that she was shorting herself on insulin, and that vicious cycle of her going back with recurrent exacerbations of her diabetes. Luckily, we have a comprehensive care team in my primary care environment. Our PharmDs were able to get her the medication she needed to bring her blood pressure and her diabetes under control. We got her into regular face-to-face care at our practice. And most importantly, we got her referred immediately to a local dental practice that was able over the next several months to help her with her dental issues. And the patient did very well and was able to get healthy and to have her other diseases in check because her oral care was taken care of. So I tell this story because it illustrates the importance of integrating oral health and primary care. This report is an affirmation that the mouth is part of the body and the oral health is health. For at least 1/3 of Americans, oral care is unreachable. They live in pain or visit emergency rooms like my patient did because the current system of care is hampered by high costs and too few oral health providers. The patients in our healthcare system pay the price of unmet oral health issues. There's also a larger economic cost from missed work and school days. In addition, the COVID-19 pandemic has highlighted the deeply embedded structural racism and inequities within our healthcare system that contribute to poor health and economic losses. One essential way we can address these inequities is by integrating oral health in primary care. This can improve the overall health of everyone. It's not only an economic imperative, it's also a moral one. We need a model of care, one that enables oral health to be part of primary care and that expands who can deliver oral care. And we need a payment model that supports this integration. Primary care offers an important opportunity to better meet patients' oral health needs across the socioeconomic spectrum. Today, we'll explore the many innovative ways this integration is being achieved across the country so that we can collectively work to reunite oral health and primary care with the aim of improving health access, health outcomes, and health injustice. And now I turn it back over to Anne.
Thank you so much, Darylyn, for your remarks and for the story about your patient. That was really inspiring that she finally got the care that she needed and deserved. Now I'd like to introduce Lisa Simon, who will walk us through the report. Lisa is a fellow in oral health and medicine integration at the Harvard School of Dental Medicine, and so she straddles both the oral health and the primary care fields. She's really the living embodiment of the report. Over to you, Lisa.
Thank you very much, Anne, and thank you everyone for joining us today. I'm so excited to share with you some of the really remarkable work that's been assembled and brought together by the PCC and Carequest. And Nina, thank you kindly for moving the slides forward. I hope this serves as a little bit of a way to whet your appetite and drives you to read the entirety of the report, because there's simply too much in it to share with you in just 10 minutes. As we've already discussed, and perhaps many of you on this call today are intimately aware of, oral health is a market inequity within the United States. 1/3 of Americans don't have dental insurance, about twice as many as have medical insurance. Uninsured and publicly insured adults make up 70% of all emergency department visits for a dental problem. And it's worth noting that 2% of all emergency department visits are actually for a dental problem, even though most emergency departments are not equipped to treat these oral health problems. This results in 321 million lost hours of work and school. But I think these numbers don't unveil the true cost of oral health inequity, which is, sorry guys, I'm being told that I'm too quiet, which I assure you is almost never a problem for me. Can I just get a confirmation that I'm audible currently? Okay. Thank you all. I can use my teacher projection voice, great. The true cost of inequality in oral health is that it is an avoidable form of suffering that is disproportionately represented among vulnerable identity groups in the United States. And no amount of work or school or other associated medical outcomes can really reflect how unjust that is. When we first started assembling this report, it was in, understandably, a very different environment back in January of 2020, which feels roughly a century ago. Obviously, we are releasing this report in a very different format and in a very different setting than we could have imagined. But through the course of developing this report, through some of the most historically challenging times our country has ever faced, I think myself and all of my colleagues who helped assemble this report believe that it is more important than ever. It is impossible to talk about oral health in America without talking about inequality, because the experience of having teeth, the experience of having dental pain, is entirely different based on structural factors beyond the control of most of us and most of our patients, unless we change things on a systematic level. This year has laid bare the structural racism, environmental injustice, financial inequality, all of the things that have rent through the heart of the United States, through our healthcare system, and are perhaps best reflected in oral health, which remains siloed and in many ways most inaccessible compared to other parts of the healthcare system. As we move towards change and feel a great promise for innovation and for restitution for some of the wrongs that have been experienced by many in America, and especially within the healthcare system, we can't succeed if we don't include oral health. And we hope that this report provides a reminder and a prompt for all of us to work towards that. There is no equity and no health equity without including oral health. As a framework for our report, thanks Nina. Just to briefly describe the way this report was developed. This was intended to demonstrate some of the many, in fact, over 100 exemplars of oral health integration that show what is possible, that show what we can imagine and what we can bring forward into optimal primary care practice. This included conducting literature review in both the published and the gray literature, and perhaps most importantly, an absolutely amazing, diverse, and expert advisory group with people with content expertise in multiple realms regarding oral health, health policy, primary care, practice, and research. With all of this input, we were able to produce a report, and I would like to use the next slide to just show how remarkable this group of people has been and express my gratitude to all of them. It goes without saying that a single advisory group can't truly reflect the wide amount of expertise that is present in this topic and might even be present on this call today. But I couldn't be more grateful to have the opportunity to work with so many experts on this report. As a fundamentals framing structure for our report, we use the Primary Care Collaborative's shared principles of oral health. These are a multi-stakeholder developed group of 7 principles that I think all of us can agree reflect the best model of what we want primary care to be, as providers, as clinicians, as patients, as people. It reflects an individual-based, personalized, structurally focused format of providing primary care, which isn't possible without oral health. Using this structure, we were able to highlight both how oral health furthers these shared principles and ensures that we're more able to meet them, but also demonstrates the ways in which oral health is foundationally centered within these principles too. And by paying attention to people's oral health needs, we are treating them as whole people. I'd like to give a couple of examples, again, just as a sort of a palate cleanser. Keep in mind, there are many hundreds of examples that I could have shared. So these are just a few, and you'll learn some more about others later today. For example, for Principle 2, which is continuous care, we focused on many different organizations that have done important work regarding the age continuum and the specialized oral health needs of very young people, people in various stages of life, as well as in the transition through the life spectrum. At Klamath County Public Health, a program was started that provided comprehensive dental care to pregnant women who were low income. As a result, within 2 years, the county's 2-year-olds had 30% fewer caries than in neighboring counties, demonstrating that providing family-focused care with a longitudinal perspective has dramatic impacts in subsequent generations. In Principle 4, team-based and collaborative, we discuss the critical work of independent tribal nations, as well as the Alaska Native Tribal Health Consortium in bringing dental therapy to Indian nations and sovereign tribal states, which allows these nations to provide the culturally competent and culturally appropriate care for very high need areas, utilizing the principles and training that are needed. And in Principle 5, coordinated and integrated, among other places, we've shared information about organizations that are leveraging oral health and primary care and integration with providing for patients health-related social needs and other social determinants of health. For example, in Neighbor Care Health, the electronic health record is integrated between medical and dental, allowing primary care clinicians to conduct oral health screenings and include an immediate dental clinic appointment within their primary care visit. At Albuquerque's Healthcare for the Homeless program, the integrated EHR also includes screening for health-related social needs, which can be further integrated into both dental and medical visits. I think that as both a physician and a dentist, one thing that has tended to be true in my experience is that the siloing of dentistry has made it harder for us to unify with other initiatives, as well as to learn from what has come before. One of the most amazing parts of working with the Primary Care Collaborative on this project is that they have such a legacy of leadership and knowledge about primary care innovation more broadly and how oral health can fit in. The Patient-Centered Medical Home Initiative and prior and ongoing efforts to improve behavioral health integration in primary care offer a blueprint for what oral health can achieve, what we can and shouldn't do, and where we can see ourselves triangulating amid all of these things that are so important to optimizing our patients' health and their health outcomes. These chapters are critical to our overall model of what this report can be. And then we end with a chapter that focuses on the future, where I hope we all can focus. One of the most amazing things about looking through all of these examples and sharing them with you today and in the report is that what's most remarkable about them is that they've achieved so much in spite of and not because of the structures in place to support oral health and primary care integration. On the basis of what we share and on the basis of these 7 principles that we imagine oral health should be, We invite you all to participate in a future world where things are easier and where more people can achieve these things. The three key features of this future and for future oral health integration are expanding oral health coverage and access, which of course are not one and the same, to align oral health and primary care with payment models and various practice innovation within the primary care sphere, and to grow the oral health workforce, most critically to diversify it and to include additional oral health team members, such as dental therapists. Thank you so much to everybody, and thank you especially to Anne. Back to you.
Thank you so much, Lisa. It was wonderful to hear your presentation and also to hear the examples. And now we're going to lift those examples that are throughout the entire report up further by inviting two leaders from organizations who are embodying primary care and oral health integration. Let me first introduce Amit Acharya, who recently was the executive director of the Marshfield Clinic Research Institute, a division of Marshfield Clinic. And that's an integrated healthcare system with more than 50 locations in Wisconsin. And then we will hear from Mike Helgeson. He's a dentist and founder of Apple Tree Dental, which operates 8 centers for dental health in Minnesota. And his organization is growing. First, let me turn this over to Amit.
Good morning, everyone. Thank you so much, Anne, for your leadership and the kind introduction. I want to commend the Primary Care Collaborative's initiative to advance oral health and primary care integration and congratulate them on the release of this new report. I also want to personally thank each and every member of the advisory group, Dr. Simon, whom you just heard from, Anita Glicken, and Dr. Minter Jardner, Dr. Meyer for their key leadership, and many others who led this important work. And last but not least, I want to thank Carequest Institute for Oral Health for the funding this key initiative. Dr. David Satcher issued the first Surgeon General report on oral health in the United States in 2000. He drew attention to a prevailing oral health access crisis, as well as the key concerns around the oral disease, which he dubbed as the silent epidemic. Dr. Satcher's report resonated with the Marshfield Clinic, a large rural healthcare system established in Wisconsin, where a statewide growing dental access crisis was in progress at that time. This inspired grassroots efforts by Mr. Greg Niche, Executive Director of the Family Health Center, and other leadership within the Marshfield Clinic to establish a practice-based multi-site dental infrastructure that was integrated into a regional multi-specialty medical clinic serving a large rural population. Marshfield Clinic is one such example of healthcare system that this report calls for action to better integrate oral health care and primary care for patients and the population it serves as part of the solution. I wanted to provide a brief synopsis of the key medical dental integration efforts that undertook in the last 2 decades at the Marshfield Clinic. Expansion of the community-based dental care model. They say it takes a village, which was very apt in our journey. At the request of the state official, the Marshfield Clinic and the Family Health Center staff collaborated with the leadership of the Access Community Healthcare in Madison, Wisconsin, to develop a blueprint for how Wisconsin Fqhcs could aid state efforts to address the dental access crisis. Marshfield Clinic and the Federally Qualified Health Center arm of it, a strategic plan refined by the blueprint and the early build-out experience as part of the first dental center that was established towards later half of 2002, served a key area for us to focus on. The plan highlighted 3 goals required to establish an effective care delivery model. Number 1, build multi-practice dental centers responsive to the access needs. Number 2, achieve medical dental integration. Co-location was ideal, but it was hard for us because we were relying on building the dental access after our medical centers have been kind of operating for many decades. So we kind of really used a virtual integration model, which we integrated the medical dental record. And last but not least, the third was to accommodate special needs patients. Our executive director's mantra, if you hear him, he always said, leave nobody behind. creating the oral health access as we kind of started out in 2002 towards the end of that has now kind of led to 10 federally qualified health centers under the Marshfield Clinic umbrella, serving mostly rural population within central, northern, and western region of the state in Wisconsin. And as we started out in the early days, it was closer to 3,000 to 4,000 unique patients that we were providing dental care access to. But now we have reached a little about 60,000 unique dental patients that we care for from all of the Wisconsin's 72 counties, as well as upper, Peninsula and the Michigan and, other surrounding states. Now, as the access was developed, we really focused our efforts into advancing this transformational vision through medical and dental integration. To promote holistic care delivery, the Marshfield Clinic developed a regional integrated medical dental electronic health record to support the health system's 1,100 plus medical providers, physicians, and many other medical providers, as well as 50 plus dentists and almost 40 plus dental hygienists. Developed by a team of at Marshfield Clinic, Cattails Dental represented adaptation of an open source dental software, which some of you may know, Open Dental, that was integrated into Marshfield Clinic's proprietary Cattails MD, which was the electronic medical record. The medical record itself was developed in the late 1980s, and during 2010, the dental component was integrated into this to better support the many patients that kind of walked into our dental and medical center. An internal analysis using the 2016 data determined that more than 70% of the dental patients also received medical care at the Marshfield Clinic within the previous 5 years. This overlap suggested potential for integrated patient care, including opportunities for triage, clinical e-alerts for patients surrounding appointments, access to clinical decision support tools in terms of, for example, screening for undiagnosed diabetic patients in the dental centers to kind of, really doing the oral visual examination for known diabetic patients from the primary care providers. Kind of having these alerts at point of care for our providers was kind of integrating it into the key practice situations and scenarios. And also, access to relevant clinical data during patient encounters, such as appointments, health status, treatment plan, problem list, diagnosis, were all kind of centralized so that irrespective of, what your medical specialty are, whether it was dentistry, you would have access to all of our patients, that they treated. Finally, I want to touch upon some opportunities and challenges, as we went through the journey. Marshfield Clinic's dental initiative has substantially contributed to regional access disparity reduction. However, future impact depends on organization's success in maintaining existing partnership and extending relationship in productive ways. With respect to latter, improved patient and medical providers' oral health literacy is critical to furthering patient activation and compliance with preventive care regimes. Better preventive care compliance translates to lower cost and conserve scarce resources, especially dental providers' time and effort in rural settings. Establishing multidisciplinary care delivery models supported by integrated electronic health records can facilitate holistic care delivery, and Marshfield Clinic is a great example to really look at how that journey has been going on for almost 2 decades. If any of the webinar attendees are interested, please feel free to reach out to me. And again, I commend this report that's been kind of shared today by the Primary Care Collaborative. And I want to end my brief commentary by a quote. The best scientific thought is agreed that dentistry is a field of medicine. There is no logical right whatsoever to isolate the oral cavity from the rest of the body as if it were made up of ivory pegged and stone sockets. And this was a quote from Dr. Alfred Orr, Dean of the Dentistry at University of Minnesota from 1905 to 27, and Dean of Columbia University from 1927 to 33. Again, thank you so much for this opportunity and congratulations to all.
Okay, Dr. Helgeson, thank you so much. Amit, I really appreciated your presentation. Dr. Helgeson.
Great, thank you so much. I just want to confirm you're seeing my first slide. Great, thank you so much for the opportunity to share a few experiences from Apple Tree Dental. Again, let's see here. There we go. I'm Dr. Michael Helgeson, the CEO at Appletree Dental and one of the founders. Appletree is in its 36th year, and our mission is to overcome barriers to oral health, and our vision is to inspire partnerships that foster healthy communities. We have services at 8 centers for dental health throughout Minnesota. And we also deliver mobile care at about 145 community sites serving low-income children and their families, adults with disabilities, seniors and elders, and long-term care across Minnesota. This is a few photos of our center in Rochester, Minnesota. In 2020, we were impacted by the pandemic, and as was alluded to earlier, the pandemic and of course the murder of George Floyd are really consequential things going on right now, and I'll pick up on that at the end of this presentation. You can see that our number of visits and patients declined due to the pandemic, but you can also see in this age distribution that we're serving patients of all ages, including patients that are centenarians. So I'm going to talk a little bit about integrating oral health and primary care by sharing 2 examples. One is our long-term care program that integrates oral health with nursing care and other long-term care services. And the other is services at Appletree's newest center, the Fairmont Center for Dental Health, which is located within the Mayo Clinic in Fairmont. And it's one of 3 hospital-based centers that Appletree operates in Minnesota. We call our model of care community collaborative practice, which is collaborating to deliver oral health services where people live, like nursing homes, go to school, or receive other health and social services like medical primary care settings. It's a proactive oral health delivery model that's targeting local needs, and it engages health education and social service professionals in interprofessional care, going even beyond medical and dental. And it adds oral health services into primary care and the healthcare home model that's been kind of alluded to. This is a photo of one of our trucks leaving a center. Each day we have trucks that are going out and dropping off mobile dental units at various community sites. And then our clinicians arrive and they're connected with a cloud-based electronic health record so they can collaborate with one another from point to point anywhere in our system across Minnesota. So we use trucks to deliver these mobile offices and they're set up. These are shots in a nursing home down in Rochester. We're able to provide a full range of services in the nursing home, accommodating patients with a wide variety of special needs. But most importantly, we're able to work hand in hand with the nurses and caregivers, occupational therapists, and really work hand in hand managing the dental needs of complex patients in long-term care. So this is an example of integrating oral health and long-term care. There are new interprofessional roles. For example, our dentists become the dental director at each nursing facility. There are new roles for the nurses, the hygienists, and the dental therapists, all working together as kind of frontline clinicians in those settings, and a great opportunity to use teledentistry, which I'll touch on again a little bit later. So that's the first example. The second one is the Fairmont Center for Dental Health, which is a collaboration with the Mayo Clinic in Fairmont. So this is an example where there is a primary care medical clinic and a hospital system that are run by Mayo, but it didn't have oral health until now. So we've launched a dental clinic that is located inside the Mayo Clinic there. And again, this is a terrific opportunity, piggybacking on Amit's comments, for integrating oral health with medical primary care. It's also an example of a rural dental health access program where a center is created in a rural community to solve those needs. We have emergency department and urgent care diversion. We have health information exchange, and we're working on research collaborations with the Mayo Clinic. And again, it's a great example of using teledentistry, particularly during the pandemic, to optimize the use of clinical equipment, experiences, PPE, et cetera, to make sure when people are coming in, they're getting just what they need. And it's also an opportunity for a practice to support some of the newer payment models that are out there. So I want to share just a couple of very quick closing thoughts that the pandemic and the murder of George Floyd have really highlighted the need for proactive, well-connected health systems in the country. They've triggered the expansion of telehealth, which can optimize clinic visits. And they've called international attentions to America's long history of systemic racism and the incredible impact it has on health inequities across the country. And they're showing the benefits of interprofessional collaboration. So thank you very much, and I'm looking forward to the Q&A section.
Well, thank you. And those examples were really, truly inspiring and exciting to see what is possible, the art of the possible. Now I'd like to invite three panelists who are going to react to the report and to these exemplars and share their unique experiences. The first I'd like to introduce is Maisha Minter-Jordan, who's the president and CEO of the Carequest Institute for Oral Health. And I think Darylyn mentioned Dr. Minter-Jordan earlier. She's formerly from the DentaQuest Partnership, who has funded this project. Second is Anita Glicken. She's the strategic planning partner and project manager of the National Interprofessional Institute on Oral Health. Anita also chaired the advisory group that produced this report and is a contributing author. And finally, Cheryl Parcham, who's the Director of Access Initiatives at Families USA, who will bring the voice of patients to the discussion. Cheryl was also a member of the advisory group. Let's start with the patient perspective, because that is what all of this work is focused on. This is our North Star. How do we redesign our health system to really meet patient needs? Cheryl, what changes do patients want to see in the oral health space, particularly those that are from more vulnerable and marginalized communities, or those that have just recently lost their insurance because of COVID-related job losses?
Sure. Well, no one in the country should have to choose between getting dental care and putting food on the table, but that is exactly what people have to choose between right now, because there's a tremendous lack of coverage for oral health care, as well as a lack of integration. Millions of people lack coverage for oral health care because traditional Medicare plans do not cover oral health. It's an option in state Medicaid programs to cover adult dental care. And in the health insurance marketplace, adult oral health is not part of an essential benefits package. During the pandemic, this problem has become even more acute, because by August, 15 million people reported that someone in their household had lost coverage. And we know that they've lost dental coverage as well as every other kind of coverage. Patients have talked with us about how the lack of oral health care affects every other part of their body. And just to provide one example, a woman with diabetes, heart disease, and dry mouth due to the medications that she takes has talked with us about how she cannot eat the fibrous foods that she's supposed to be eating because of the lack of oral health care. She has bad teeth. She takes pain medications for her teeth, but cannot afford to fix the underlying tooth decay that's causing her problems. So that's one of many stories. There's a young adult with cancer who's lost the enamel on his teeth due to chemotherapy. And there are people who self-neglect, and when they finally do encounter the health system for the first time after a critical illness, they really need someone to take them under wing and meet all of their needs, and it just doesn't happen.
Thanks so much, Cheryl. So I really see the terrific, or terrible, I should say, chasm between the examples that we heard earlier about what is possible and the examples that you just lifted up, which is more the norm for marginalized and vulnerable populations. Dr. Minter-Jordan, per an announcement earlier this week, you're now overseeing a newly created nonprofit with a bold mission to overhaul the oral health system, including by integrating oral health into primary care. And I think you're uniquely able to answer this question because not only are you a medical doctor, but you also have an MBA. So what is the business case for integration, and how can oral health integration into primary care be financially sustainable for practices?
Thank you for that question, and thank you to everyone who was instrumental in putting this important report together. I'm extremely pleased to be here to lift up this issue. As a primary care physician, this is incredibly important to me as we think holistically about patients. And I think I always center on the patient and their experience, so it was really important to hear the examples that have been given thus far regarding what is a patient experience when they're entering into the healthcare system, and how can that experience be holistic and comprehensive in nature. As it pertains to the business case, I think part of what we have seen as we've seen healthcare continue to transform, particularly using the example of behavioral health, it took a lot of advocacy, it took a lot of patient voice to ensure that behavioral health was integrated into primary care. And there are differing models as to how that's happening currently, but it also took reimbursement changes and advocating for those reimbursement changes. As we built the business case for behavioral health integration into primary care, it was leveraging the full team, leveraging front desk staff, and looking at ways in which to reduce overhead expenses in order to move that model forward. Also, as we look at current models of accountable care organizations and other capitated scenarios, we're finding that the reduction in ED utilization by focusing on oral health, the focus on oral health as it pertains to the impact on chronic disease. We heard the great example of the correlation between diabetes and oral health earlier twice today during our time, and how if we are approaching a holistic, comprehensive approach to care and leveraging all the various providers within a healthcare system, we can move the needle not only on patient outcomes, but also on cost. I think the other piece that I would say is a specific example. In my prior role leading a community health center in Boston, the Dimick Center, we did a lot of work working with our pediatricians in training them to use fluoride within their visits. So they not only got reimbursed for the fluoride application, but they also, most importantly, helped to prevent disease in children. And so there are varying models as to how this can be accomplished. I think most importantly, it focuses on the integration of the primary care and the oral health providers and how they can work together to best meet the needs of the patient. And then again, looking at all of the various expenses that occur within that model and looking at opportunities to reduce those expenses through that integration. Opportunities for training of both oral health care providers as well as primary care providers to identify chronic disease on one hand and also oral health disease on the other can then help to promote different approaches as to how we can create the business case and fortify the business case to make it sustainable for patients across the board.
Thank you so much. Anita, as someone who is leading an organization focused on engaging a multidisciplinary team of clinicians to eradicate dental disease, Fqhcs have been particularly successful, and we heard that from Dr. Minter-Jordan, but also from other examples that Dr. Simon lifted up previously. Why do you think Fqhcs have been particularly successful?
Well, I think we'd all acknowledge that as the medical home for people who often lack any oral health services, Fqhcs are really uniquely positioned to provide a dental home for those patients as well. And Fqhcs are already structurally integrated organizations. They already deliver primary care, behavioral health care, oral health care, and they often avoid that degree of separation that we see between medical and dentistry in our larger healthcare system, which we know is an important barrier to integration. As integrated systems, they have long recognized that technology was a significant factor in integrating their primary care with oral health, whether it be through facilitated bi-directional referrals and information exchange, consultations with other health professionals in real time, interface with patients in community settings through their patient portals, and connecting with medical providers in the community who were really treating their mutual patients. It also permits them to monitor specific interventions and really to be able to inform future work. They use a variety of other strategies as well. For example, one of the findings is that oral health service delivery is the most effective way of improving access and utilization of oral health care when it's designed to meet the needs of their local populations. Some require that all patients who are seen in their dental clinics have to be patients in their primary care clinics as well. They discovered that the demand for oral health emergency services was extremely high, and that may be a direct indication of a lack of literacy. So they prioritize primary care to educate patients about the importance of periodic preventive visits and the patient-centered home. Fqhcs commonly utilize all kinds of different team-based approaches to meet patient dental demands. Typically, those always include dentists, dental assistants, dental hygienists, dental residents, and some school-based health programs, but they now also include these new interprofessional oral health workforce models to include care delivery. Some engage primary care teams, and other engage new oral health professionals like dental therapists who are approved or recognized in their own state. I think overall, Fqhcs recognize that their clinics are interprofessional partners in healthcare delivery, and that community linkages and linkages to other health professions are really essential to meet the needs of patients for comprehensive care delivery.
Terrific. Thank you so much. I'm going to ask just one other question of the panel, and then we're going to open it up to questions from the over 350 participants who have joined us this morning. I would, and really anyone on the panel can take this question, or multiple folks can. We obviously have a new Congress, a new administration. We are coming off of, the very devastating effects of COVID-19, and obviously not through it yet. You all have been working to enhance oral health and working on integrating oral health in primary care for now decades. What is your sense of the political and policy environment for moving us forward? Given the changes of last year and all that we've been through, and also our new political environment. Who would like to take that question?
I could start.
Yeah, please go ahead, and then I'll chime in.
We were really gratified last year to see a number of bills introduced in Congress, and one actually passed the House that would improve oral health coverage. So it's a good time to be working on oral health coverage in Medicare and elsewhere federally. We've also been encouraged by state Medicaid programs that are stepping up to transform oral health and make oral health and integrate oral health. There's a tremendous opportunity on the state level to make steps in this direction.
I would agree with that. I'm optimistic. We do have a study coming out from the Carequest Institute later in the beginning of April regarding the healthcare inequities. And we know that 6 million adult Americans have lost their dental insurance. So the time is now for us to activate and for us to leverage this new administration in putting forth the needs of those who've been marginalized and underserved and who have experienced health inequities, understanding that that pool has only gotten bigger. And so one of the things that I'm really excited about is the opportunity to work with this new administration, the opportunity to continue to drive the conversation regarding inclusion of oral health benefits in Medicare, as well as to continue to work with all the various states in the expansion of Medicaid coverage, so that in many states we're moving beyond only emergency covered care. We know that many others have canceled or put off their important preventative care in the last year. Nearly 4 in 10 adults have delayed care because of the costs of care and lacking insurance. So we know that the demand and the need is out there, and I'm excited about the opportunity to really to push forth this agenda.
I'd like to add one additional perspective, and that is from where I sit as chair of the Advisory Committee on Training in Primary Care Medicine and Dentistry. One of the questions in the chat was, how do we address the barriers and the opportunities in interprofessional education to integrate oral health into primary care? So I'd like to just share that what I'm seeing from the federal perspective through that role is that our committees are working closely together to make sure that we recommend that there is appropriate support and funding for those educational programs that could help our a broad broad sectors of our healthcare workforce have the funding they need to train up and ready the workforce for these new transformative models of care that we're talking about today.
Just one important advance that I was really pleased to see was the inclusion of oral health providers in the vaccine distribution. So I think that recognition is meaningful and also opens the door to longer conversations and more conversations regarding oral health providers as part of the larger healthcare ecosystem, and really moving away from the siloed nature with which we have traditionally approached oral health.
Mike.
Yeah, I just want to echo and reinforce everything that's been said so far. I do want to highlight that I think the connectedness of world health and the fact that these pandemics impact everyone really highlights the need for universal access to healthcare. And I think adult Medicaid coverage in all the states is looking more likely now. I'm excited about that. The work on a Medicare dental benefit is moving forward, and I'm excited to see that happening. And then I do think in the Medicaid, Medicare dual eligible space with accountable care organization and integrated health plan contracting, there's finally an opportunity to look into all the different silos, wasted money on transportation, for example, when services can be delivered right at schools or nursing homes, and you can avoid those costs. The use of telehealth to eliminate unnecessary in-person visits and be able to reduce all the transportation and PPE expenses related to non-productive in-person visits. By triaging and using telehealth to the max, you can really take full advantage of each in-person visit. So I'm excited. I think this has really highlighted a lot of gaps in the current system and is putting pressure on all of the various systems to adapt and provide better integrated care across not only medicine and dentistry, but education and behavioral health and social services and long-term care. I think it's, with this increasing knowledge about social determinants of health, this message that it really takes the whole community to take care of health inequities. I think that's really coming through loud and clear. And I just want to salute everybody for a fantastic report. What a beautiful collection of great work.
Thank you so much. We're getting additional questions, and actually back to you briefly, Mike. The one question is, how can we encourage more integrated delivery systems like Marshfield Clinic or others in the private sector? You mentioned ACOs to really embrace integrated oral health care. I mean, what additional incentives do you think we need to spur adoption?
Boy, I think within the Medicaid space, funding for pilot projects, I'm all about demonstrating and piloting and proving things work. I think that would be wonderful. I do think more support for interprofessional education, that's already been mentioned. It's difficult for clinicians to go out and do things that they weren't educated how to do in their program. So I think support for all the various medical, dental, nursing, pharmacy, physical therapy, interprofessional educational opportunities where they can actually work together in teams while students. I think we have something in Minnesota called Clinical Dental Education Innovations Grants that come out every year, and they are intentionally require a local healthcare partner to work with an educational organization. And they also have to have a health equity impact. And these have been in place for maybe 10 years. We have about 800 student rotations every year and a half just at Appletree, where different kinds of health professional students rotate. So expanding that kind of thing across the country, I think would go a long way. So there's a couple of ideas.
Terrific, thank you. This is a question from Jack Westfall, who's at the Graham Center. And maybe, Anita, you'd want to take this first, and then others may want to jump in. Can you describe the balance between integrating dental clinicians into primary care as well as training primary care clinicians about basic dental care, such as assessments, hygiene, and fluoride varnish? Cavity-free at 3 in Colorado is an example, but you may have others, and would love to hear your reflections.
Yes, I mean, I think it's really critical that we look both at the primary care role of dental clinicians as well as the role of our primary care clinicians in providing that oral health care. There are some great tools and resources out there, as you mentioned, Jack, Cavity-free at 3 in Colorado, and also Smiles for Life, which is really the nation's most widely used and most comprehensive oral health curriculum. That's endorsed by 8 different health professions, including dental professionals. And it's used to train up the entire workforce and often the entire healthcare team at places like Marshfield Clinic and other Fqhc settings to really help all providers recognize that they have a primary care role in delivering comprehensive care to their patients. So I think we see that as really very bidirectional in nature and benefit to the patient as well.
Thanks so much. Here's a question from Janelle Miller from Helio. Can you provide more details about how primary care clinicians can ensure they're paid for providing oral health services?
I think there are a number of ways in which that can happen, particularly within the context of accountable care organizations. There's a capitated cost. So the goal for the primary care providers and for those providers that are in that system is to not only improve the patient outcomes, but reduce the overall cost. So as you begin to look at the number of patients that you have within your panel and who are seeing a dentist, part of what you'd want to do is ensure that they're getting regular preventative care, because we're really focused on prevention rather than actual surgical treatment as much as possible. Looking at those patients who have chronic diseases and ensuring that they are prioritized. Looking at pregnant women, again, ensuring that they are prioritized in terms of their oral health. And as you begin to ensure that they have access to oral health and most importantly, prevention, we will see a reduction in their overall cost of care because of that correlation between chronic disease and oral health. Additionally, I mentioned the fluoride example earlier, and as we continue to work with and collaborate with others who are moving more towards prevention and leveraging different tools like silver diamine fluoride application, those are ways in which we can increase the reimbursement for the primary care provider. And more importantly, I think the real goal is to create and look at the example of behavioral health and primary care as a means to create more collaborative relationships between oral health care providers and primary care providers to look at other ways in which you can move towards better reimbursement for those services.
Thank you so much. Sue Keller made a very good point. She's been in private practice dentistry for over 25 years, and she loves hearing about, a lot of the things that are going on in Fqhcs and other places that are receive public funding. But she's frustrated that the private care is way behind in terms of integration. So I'm wondering if folks can comment on that and how we really move things along on the private side.
And Amit here, if I may. So
Sure.
I think it comes back to what Maisha, a key point that Maisha alluded to. There are 2 core elements. One is the quality when you integrate medical and dental care. It's unfortunate that historically that dentistry is practiced a little bit outside of medicine, but we need to look at this from the patient's perspective. And there are several literature and pilot that are done there, and also looking at some of the payer side of the data. If we can really manage the patient's oral health for especially some of the chronic condition patients, I think there are financial models that are out there that could then be kind of, really designed in such a way that, whether you're a medical provider or a dental provider, it's part of the care team approach. And then the other point, again, Maisha brought up the quality of care. A lot of the pilots, if we can really focus on kind of, better integration, looking at those quality measures. So a good example, we've been on this topic today of diabetes. we know it's bidirectional. Some of the microvascular complications of diabetes shows up in the mouth first, but unfortunately, physicians are not necessarily looking for those, or not necessarily kind of completely trained, and vice versa. From the dentist perspective, we are mostly looking at kind of the dental issues. So the quality of care is a great way to kind of pilot a lot of these, medical dental integration. And definitely the financial incentive models are there to better, reform.
Well, thank you all. We have so many more questions in the chat, and I know we could continue this conversation for many more hours. This has been a really, really rich discussion today. We are very excited to be releasing this report. We want to thank again Carequest Institute for their support, the advisory members for all of their tremendous input, and all of you for joining us here today. A recording will be emailed to all of you. We'll have the report available on our website. Thank you again for coming to our event today. And please join with us in working to integrate oral health into primary care. Thank you now.
Thank you so much.
Thank you.
Thank you.
Thank you.
Thank you.